Usually when we think about going to the doctor, we expect, I don't know, mechanical precision. Like you take your car to a mechanic, they plug it in and tell you exactly what's broken.
Right. We desperately want the human body to be just like a machine. You know, you break an arm, you see the x-ray, and it's a simple fix.
Yeah, exactly. But then you step into the world of trauma and neurobiology, and suddenly that whole mechanical idea just shatters.
It really does. The diagnostic landscape gets incredibly murky when we start looking at how lived experiences physically alter our internal structures.
And that is exactly what we're doing for you today. We're on a mission to unpack a fascinating stack of medical guidelines, anatomical research, and trauma care protocols. We want to answer a highly specific, but honestly, deeply profound question. How does a prior history of sexual trauma physically alter the vascular and muscular response of your pelvic tissues during an elective medical exam for vaginal dryness?
It's such a vital question because, we often separate the mind and body in medicine.
Oh, totally. Like they're in two different zip codes.
Right. But today's sources prove that separation is a complete myth. Psychological trauma translates directly into measurable physical and vascular changes in the body.
Okay, let's unpack this. Because to understand how trauma hijacks the body's response, we first need to understand the physical baseline of the dryness itself. Right?
Exactly. And the sources focus heavily on a condition called genitourinary syndrome of menopause, or GSM.
Right, which some people might know as vaginal atrophy. And reading the clinical descriptions, I kept trying to visualize it. I kept thinking about, like, your lips in the dead of winter.
Oh, that's a good analogy.
Yeah, like they're incredibly dry, chapped, and if
Yeah.
you smile too wide, they might even crack and bleed. They just desperately need moisture.
It is a useful starting point, for sure. But the winter lips analogy only really captures the surface level friction. The stakes here are actually much deeper.
What do you mean? Like deeper than just surface moisture?
Yeah, because we aren't just talking about cold air. We are looking at a systemic cellular withdrawal of estrogen.
Which is a huge deal for that part of the body.
Huge. We tend to think of estrogen purely as a reproductive hormone, but it's actually a profound vascular regulator.
Right, it controls blood flow.
Exactly. The genitourinary tract, so the vagina, the vulva, the urethra, is packed with estrogen receptors. When those hormone levels plummet, the body essentially shuts down the local infrastructure.
So it's literally losing its blood supply. That sounds intense.
It is. Estrogen is the chemical signal that tells the blood vessels in the pelvis to stay dilated and active. Without it, you get a sharp, chronic reduction in blood flow. The
Wow.
tissue is basically being starved, and that lack of blood flow makes the vaginal lining visibly thin and fragile.
And there's a structural change too, right, with the rugae.
Right. Healthy vaginal walls have these folds called rugae. Think of them like the pleats of an accordion. They allow the tissue to stretch without tearing.
But with GSM, those pleats they disappear.
They flatten out entirely. The underlying collagen and elastin fibers degrade without blood flow. The tissue completely loses its elasticity.
Which leads to something called petechiae, right? I saw that in the clinical papers.
Yes. Petechiae are tiny pinpoint bruises on the skin surface.
But wait, why do they form just from a lack of estrogen?
Because the capillaries, the tiniest blood vessels, become incredibly brittle. Without estrogen structural support, they literally snap and leak blood from almost no pressure at all.
Oh, wow.
Yeah.
Okay, so picture that highly fragile, thinned-out tissue. Now, if someone needs an exam for this, the doctor has to physically look at it.
Right. And traditionally, that involves a very specific physical setup.
Yeah, the lithotomy position. You're lying flat on your back, knees drawn up, legs apart in stirrups, and the doctor inserts a speculum to check for narrowed walls or those petechiae.
That's a very standard procedure.
But logically, if the tissue is already deprived of blood flow and physically fragile from low estrogen, wouldn't the mechanical friction of that exam naturally cause severe discomfort for anyone? Trauma or not?
You might assume that, yeah. But there's a massive biological distinction we have to make here.
Okay, tell me.
For a non-traumatized patient, severe GSM discomfort is usually a dull, frictional ache. It's uncomfortable, absolutely.
Right, it's sensitive.
But for a trauma survivor in that exact same exam room, it is a violent ischemic lockdown. It goes from uncomfortable friction to an excruciating systemic event.
Wait, really? It's that drastically different?
Oh, entirely. It might even make the exam physically impossible to perform. And this has absolutely nothing to do with their baseline pain tolerance.
Okay, this is the part I really want to untangle. If the trauma happened years, maybe decades ago, how does a psychological memory reach down and strangle the blood supply to the pelvis in the present?
Well, the biological bridge between the brain and the pelvic floor is the hypothalamic pituitary adrenal axis, the HPA
Okay,
axis.
the HPA axis.
Right. Early life stress or sexual trauma permanently dysregulates these stress systems. It creates a high allostatic load.
Allostatic load meaning the wear and tear on the body from chronic stress.
Right. Exactly. If we connect this to the bigger picture, a healthy nervous system resets after a threat is gone. But in a trauma survivor, the chemical receptors undergo altered neuroplasticity.
So the system gets permanently hypersensitized.
Yes, it gets stuck scanning the environment for danger. The alarm system is rewired to be far too sensitive.
And reading through the HealthWatch Liverpool report and the Survivor's Trust guidelines, it's obvious a standard doctor's office is a minefield of danger signals.
Oh, absolutely. The triggers are built right into the exam.
Right. The intimate nature of the exam, the commanding language, the unequal power dynamic, you're physically exposed while a clothed professional stands over you.
And for a survivor, these environmental cues hijack that hypersensitive HPA axis. They trigger intrusive memories or even complete dissociation. It's re-traumatization happening in real time.
That's terrifying.
It is. And the crucial reality is, this isn't a conscious choice. The psychological trigger instantly activates the sympathetic nervous system.
Which is the body's fight or flight response.
Exactly. It's a hardwired survival mechanism. It instantly dumps a massive cascade of stress hormones into the bloodstream.
Okay, so let's map that chemical dump onto the pelvic tissue. When the sympathetic nervous system goes into full survival state, what happens to the muscles and blood vessels right as the exam starts?
Well, we have to rethink the anatomy a bit. You might think of the pelvic floor as a passive hammock.
Yeah, I totally thought of it like a hammock supporting the organs.
A lot of people do. But when responding to an attack, a hammock is the wrong image. You have to think of it much more like a thick, highly dense sponge.
A sponge, okay.
Yeah, a powerful muscle sling. And crucially, all the major blood vessels and nerves thread directly through that dense muscle to reach the organs.
Right, so they're all tangled up in there.
Exactly. Now, when the brain screams threat, it commands those muscles into hypertonic contraction. They spasm violently.
Like wringing out the sponge.
Yes. Imagine grabbing that sponge and wringing it out with a white knuckle grip. The muscle spasm acts as an internal tourniquet. It physically crushes those neurovascular structures shut.
Oh my God.
In the medical literature, this is known as the neurovascular compression model.
So the muscles are literally strangling their own blood supply.
They are, but there's another layer. While it causes that local spasm, the sympathetic overdrive also causes systemic vasoconstriction.
Narrowing the blood vessels everywhere else.
Right. It shunts blood to your limbs and heart so you can fight or run away.
So the pelvic vessels are chemically narrowing themselves, A and D being physically crushed from the outside.
Which results in severe ischemia, inadequate tissue oxygenation. The blood flow is severely restricted.
Okay, but here's a question I had, and maybe you listening had it too. There's a specific quote from the sources about having pain and how it's not as simple as just relaxing or having a glass of wine.
Right. That's a huge misconception.
So why can't the patient just take a deep breath, relax for 30 seconds, and let the doctor finish?
What's fascinating here is the biochemistry of ischemia. It makes relaxing physiologically impossible.
Wait, impossible? How?
Well, when the tissue is starved of oxygen, the cells still need energy, so they switch to anaerobic metabolism.
Okay.
And the byproduct of that is a massive buildup of chemical metabolites, particularly lactic acid. And because the vessels are clamped shut, the acid pools in the local tissue.
Like the severe burn you feel during a wall sit exercise, but inside an internal organ.
Much more acute than a wall sit. These trapped chemicals trigger specific sensors called nociceptors.
Biological fire alarms.
Exactly. Bather in lactic acid, they send urgent, screaming pain signals straight to the brain.
And the brain is already panicking from the trauma trigger.
Right, so it registers intense chemical pain from a vulnerable area, and it orders the muscles to clamp down even harder. This triggers actual severe muscle spasms like vaginismus.
Wow, so it's a vicious cycle. The anticipatory anxiety causes vasoconstriction and tension. That leads to ischemia and lactic acid pooling. The acid causes excruciating chemical pain, which prevents relaxation, makes the dryness worse, and leads right back to more muscle guarding.
Exactly. The trauma survivor is experiencing a genuine vascular event. It is not just anxiety in their head. Their pelvic floor is chemically on fire.
Here's where it gets really interesting. Because obviously, these patients still need medical care for their GSM. So how do medical professionals actually perform these exams?
That's the hopeful part of the clinical guidelines. There's a vital shift happening, like the hashtag Check With Me First campaign by the Survivors Trust.
Right, they have very specific trauma-informed guidelines. And it's not just about having a good bedside manner, is it?
Not at all. Trauma-informed care is applied neurobiology. The provider deliberately engineers the environment to short-circuit the trauma response.
They're changing the physical and environmental cues.
Exactly. For instance, positional changes. Instead of the triggering lithotomy position, they might examine the patient in the left lateral position.
Lying comfortably on their side.
Right. It avoids that vulnerable, physically exposed feeling.
And they also change the instruments, right?
Yeah.
Like using a smaller or pediatric speculum.
Yes, to reduce the mechanical stretch on that fragile tissue. But honestly, the language shifts are incredibly powerful too.
Yeah, I saw that. Instead of saying, open your legs, doctors are trained to say, let your knees fall to the outside.
Right. It removes the demand from an authority figure. And the pacing is entirely different. They explain every step before it happens.
Giving the patient complete control to stop the exam at any point.
Exactly. That autonomy fosters a profound sense of safety.
And how does that safety physically change the tissue?
Well, when the brain feels safe, it calms the sympathetic nervous system. It reduces the vasoconstriction.
The internal tourniquet releases.
It does. It allows the pelvic floor muscles to downtrain or relax. Fresh blood flushes away the lactic acid, and the exam actually becomes physically possible.
That is just wow. So what does this all mean? We started with a routine exam for dryness and discovered that for a trauma survivor, it can trigger a physiological cascade where the nervous system restricts blood flow and causes real chemical pain.
Right. The most important takeaway is that these symptoms are not in a patient's head. All pain is real.
Yeah.
The medical model often highlights pathology, making it seem like something is wrong with the person. But these vascular and muscular spasms are actually incredible, if misplaced, adaptations to survive past trauma.
They're just deploying those defenses at the wrong time. It really shows how our biology is entirely permeable to our biography.
Beautifully said. Every lived experience leaves a physical footprint.
Which leaves me with a final thought for you to ponder today. If trauma can so radically alter the blood flow and muscle tension in our pelvic organs during a 10-minute medical exam, how might our daily unaddressed microstressors be quietly reshaping the vascular health of the rest of our bodies right now?